the Saudi Society of Bone Marrow Transplant. It's a webinar series every Saturday, and today our topic is about invasive fungal infections update in hematology setting. Very important topic for all our hematologists, especially with those days with many immunocompromised patients around our hospitals. I'm very glad to introduce Dr. Johan Martens. He's an associated professor of hematology in the Department of Hematology in University Hospital of Gothenburg, Leuven in Belgium. Dr. Johan is well-known in the Infectious Disease Society. He was the past chair for the Infectious Disease Group of the European Organization for Research and Treatment for Cancer, EORTC, and he's the founding member and the current chair of the European Conference of Infection in Leukemia, ECIL, which we use for many guidelines, and major interest for Dr. Johan is fungal and viral infection in patients with hematological malignancy and immunocompromised patient. Dr. Johan will talk today about the update in hematology setting of invasive fungal infection. Please, Dr. Johan, go ahead.
Well, thank you very much. Let's see if I can share my screen.
While you share your screen, I want to thank Gilead for sponsoring this webinar, and we can see your slide, Dr. Johan. Please proceed.
Okay, perfect. So, good evening, everyone, and thanks to the organizers for having me at this meeting, at this webinar, to talk today about the management of invasive fungal diseases in patients with an underlying hematological malignancy. And basically, I will address the question whether the empirical approach or the empirical treatment of these patients is still appropriate, and if it is still appropriate, what could be the drug of choice in that particular setting. And I will mainly focus on liposomal amphotericin B. Now, here you can see my disclosures, conflict of interest. As you can see, I've been working with quite a lot of players in the field of medical mycology, both developing new drugs, but also developing new diagnostics. So every talk on fungal infections should start with a word on epidemiology. So really the question here is, what is the problem and what is the size of the problem if we talk about invasive fungal diseases in patients with an underlying hematological malignancy? And I think this is an important question because we know from our classes or courses in psychology a long time ago that the size of a reaction should always match the size of the problem. So if I talk to some of my colleagues, then for some of them, invasive fungal disease in hematology is a big problem, and for others, it's only a small problem. And that brings me immediately to one of the main issues, that is data on epidemiology. Epidemiological data on invasive fungal diseases in patients with underlying hematological malignancies are really very sparse, and we have a lack of data in different continents, different countries, different institutions and departments. Really what we need is more updated data on the epidemiology of these infections. If I just look at what is available in Europe, then I have to say that this is the most recent update coming from the PIMDA study. Now, the PIMDA study was a prospective audit that was done in quite a number of European countries, looking at the incidence of invasive mold disease in patients with AML or myelodysplastic syndrome receiving intensive chemotherapy, or patients undergoing myeloablative allogeneic stem cell transplantation. And really, this was a period prevalence study, so all the patients were followed for a period of 6 months from the start of chemo or the start of their transplantation, and we looked at the incidence of invasive mold disease. And as you can see, we had almost 1,200 patients that were eligible in this study, about half of them AML MDS, and about half of them underwent myeloablative allogeneic stem cell transplantation. And if you look at the incidence of proven and probable invasive aspergillosis, and it was mainly aspergillus, we did have some patients with mucor infections. But if you look at the incidence of proven and probable invasive aspergillosis, that's around 9% during remission induction treatment of AML, 4% during the consolidation treatment. And to our surprise, it was only 4.7, so below 5% in the myeloablative allogeneic stem cell transplant recipients. If one also includes the possible cases defined by quite specific features that were seen on imaging, mainly on a CT scan, then the numbers go up significantly from 9% to 20%, from 4% to almost 10%, and also in the LOBMT population from less than 5% to almost 10%. Having said that, I have to say also that there were considerable differences in the incidence of these invasive infections in the different institutions and also in the different countries. So this is not what we see all over Europe. This is clearly what that may clearly differ country by country and center by center. Now, this is probably the most recent update of the epidemiology that we see in hematology patients. It's taken from a retrospective cohort study from a group in Brazil, Marcio Nucci's group, who is a hematologist of Sao Paulo. In that center, they looked at their invasive fungal infection rate between 2009 and 2019. And important here to state is that the patients that were at risk received fluconazole prophylaxis, and they had a kind of mold-directed diagnostic approach using CT scan and the surrogate markers that were available, galactomannan and beta-D-glucan. And then you see that overall, the incidence of invasive fungal infections in the population is 9.6%, significantly higher if you look at the acute leukemia population, 17%, and it was 8.9% in the allogeneic stem cell transplant recipients. Also in this study, the majority of infections were caused by Aspergillus species, followed by Fusarium. And this is particular for Brazil. Brazil really is a country where Fusarium is quite endemic. But as you can see, very few patients had invasive Candida infections, mainly because they all received flucoprophylaxis. And then you see a number of other infections that were basically rare or exceptional, such as cryptococcal infections, mucormycosis, and others. Now, do we know what the true incidence is? To finish the topic on epidemiology, no, but I think it's fair to say that the better you look for fungal infections in your population, the more fungal infections you will find. And that is clearly illustrated by this quite recent study that comes from the group of London, the King's College in London, where they actually looked at a number of hematology patients that they consider to be at risk for fungal infections, many underlying diseases, leukemia patients, stem cell transplant patients, also aplastic anemia patients. And if they only included galactomannan as one of the diagnostic markers, then their incidence was only 10.5%. When they relied on beta-D-glucan as a kind of pan-fungal marker, then the incidence in that population went up to 16.3%. And as you can see, when they throw in all the diagnostics that were available in that institution, culture, microscopy, autopsy data, but also galactomannan, beta-D-glucan, sometimes also PCR, they ended up with an incidence of 21.1%. So quite a high incidence in a contemporaneous group of patients diagnosed and treated in London. So what are now the key factors when we talk about the management of invasive fungal disease, not only in hematology patients, but really in all the immunocompromised patients? Well, I think that success really depends on four important factors. The first one is the management of the infection source. You have to have adequate source control. If you have an infected indwelling line, then maybe you have to pull the line. If you have an infected device, or you have, for instance, an endocarditis, then maybe you will have to call upon the help of a surgeon. So infection or source control is really an important element. The other element clearly is the immune status or the immune state of the host. And we all know that patients who are neutropenic, when they remain neutropenic for a prolonged period of time, then it's going to be very difficult, not to say problematic, to control their underlying invasive fungal infection. Of course, you also have to look at the pathogen itself and the drug susceptibility of the pathogen. And clearly, if you have an azole-resistant aspergillus, for instance, that patient should not receive azole treatment as first-line treatment. The problem here is that you need a positive culture, and in many of our patients, we do not have a positive culture. And so in the absence of a positive culture, it's difficult to test for the susceptibility or the drug susceptibility. And last but not least, and we talk about that today, you have to install appropriate antifungal therapy. That means that you have to give it on time, at the appropriate dose, and you also want to select the most potent and the safest drug. And that implies that you have some knowledge of the pharmacokinetic and also the pharmacodynamic of some of the agents that we can use. Now, today we will mainly talk about timing and look at the different approaches that we have, and also look at the selection of the most potent and the safest drug that we can use in this setting. So as already mentioned, it is really important to have early and adequate therapy. And the reason for that is that there is an inverse relationship between the odds to control the disease, the infectious disease, and the burden of the disease. Now, this is a general principle, not only with respect to invasive fungal infections, it's a general principle in infectiology. It's also a general principle, of course, in hematology and oncology. We all know that lymphoma patients stage 1 have a better outcome than lymphoma patients stage 4, for instance. So that inverse relationship between the odds to control the disease and the burden. And it has been shown, for instance, for invasive aspergillosis, where patients were categorized according to their baseline serum galactomannan. And the serum galactomannan here was taken as a surrogate for the burden of the disease. And then you see that those patients having a low baseline serum galactomannan have a better outcome compared to those patients having a higher baseline serum galactomannan. Now, if we have to treat as early as possible and in a very adequate way, then we have to look at the approaches that we have developed as a community. What are our interventions and our interventional options? And unfortunately, they are quite limited. And I think it's already fair to say that no single approach that we will discuss is really perfect. As already said, it is not wise to wait till you have a proven or a documented fungal infection, because then you come in too late, your intervention is going to be too late, and the mortality rates are really high. That has been shown for Candida, for Aspergillus, but also for mucormycosis. The other approach that was developed is to try to give prophylaxis very early on, prophylaxis for all patients that are considered to be at risk for developing invasive fungal diseases. Now, the true problem with prophylaxis is that you need to find a balance between the number needed to treat, how many patients do you have to give prophylaxis in order to prevent a fungal infection, versus the number needed to harm, how many patients will be overtreated, will receive unnecessary treatment, and as a result of that will have some kind of adverse event or even serious adverse event. So that balance between number needed to treat, number needed to harm, and of course there is always collateral damage. And we also will have to talk about breakthrough invasive fungal infections on patients receiving adequate prophylaxis. If I try to summarize what we know about prophylaxis in the setting of hematology, then this is really summarizing data from a large number of prophylactic studies that have been performed since the 1980s. We can say that prophylaxis has shown to decrease the incidence of proven and probable invasive fungal diseases, to decrease the incidence of invasive aspergillosis, also decrease the incidence of invasive Candida, of course. The invasive fungal disease-related mortality has decreased, but the problem is that if you look at the larger meta-analysis, that there is almost no impact on the overall mortality. And the reason why we have no impact on the overall mortality is because there are a number of drawbacks related to that general or that routine prophylaxis. And they are listed on the other side of the slide. Sometimes there are issues with compliance. There are definitely tolerability issues, especially with the oral drugs, the azole drugs. There are issues related to the safety, also the long-term safety. For instance, we know that long-term exposure to voriconazole has been linked to the development of very aggressive skin cancers in lung transplant recipients, but also in stem cell transplant recipients. We will come back to the next bullet point, drug-drug interactions. They are becoming more and more important these days. There is the need for therapeutic drug monitoring, especially if you use the azoles, to be sure that the patient has adequate exposure to the drug. There is a development of resistance, and we see breakthrough infections and shifts in the epidemiology. And last but not least, mold-active prophylaxis, be it an azole or any kind of candin or a polyene, has an impact on the performance of some of the newer diagnostics, and so they cannot be combined with prophylaxis as such. Now, I think this is an important one. breakthrough infections as one of the drawbacks, and also shifts in epidemiology as one of the drawbacks of routine prophylaxis. That was clearly shown in this study coming from the group of Cologne. The group of Cologne, with Oliver Corneli as the most important person from that group, is really very much in favor of giving routine mold-active prophylaxis, especially with posaconazole, in the AML population, but also in the stem cell transplant recipients. And when they looked at the result of that retrospectively in their population, they saw that quite a large number of these patients receiving POSA prophylaxis had breakthrough invasive fungal infections. It was about 24% in a large AML population and 12%, 12.5% in quite a large stem cell transplant population. I have to admit, most of these patients did have probable disease or proven disease, and most of them had possible invasive fungal disease. But I also think that we all agree that even patients having possible invasive fungal disease, characterized by specific features on a CT scan, will receive antifungal therapy these days. Now, this is one of the problems. If you have a patient on mold-active prophylaxis, be it an azole or an echinocandin or a polyene, and that patient, while receiving mold-active prophylaxis, develops with new pulmonary nodules, as the ones that you can see on the slide here, then your differential diagnosis is quite large. We know that in 50% of these cases, you will have an invasive mold disease, a breakthrough invasive mold disease. But in 50% of the cases, you will have a disease that mimics invasive mold disease. Now, if we stick to the invasive mold diseases, there are basically three different scenarios possible. Either that patient has an azole-susceptible aspergillus species infection, and that is the case if the patient has a low exposure to the drug that is given prophylactically, or when the infection develops in a sanctuary site, such as, for instance, the central nervous system. The other possibility is that the patient has an infection with an azole-resistant aspergillus species, and that may be acquired resistance, or that may be intrinsic resistance. And the third option, of course, is that the patient has a mold infection with a non-aspergillus mold that is intrinsically resistant to the drug that was given prophylactically. And then you have quite a long list, including Mucorales, Fusarium, Cedosporium, and Lomentospora. If we look at the mimickers of invasive mold disease, that can be basically infectious and non-infectious. And in the infectious part, that you see a number of well-known bacterial pathogens such as Pseudomonas aeruginosa, Klebsiella pneumonia, but also mycobacterial infections in nocardia. And in the non-infectious part, you may have lymphoma or cancer or thromboembolic events. Now, I've said that we don't only see a breakthrough breakthrough fungal infections, but also a shift in the epidemiology. And that is, of course, very well known. When we started introducing fluconazole as a prophylactic agent to prevent Candida albicans, we saw that we had more breakthrough infections with non-albicans Candida species. And the same is true with the availability of the mold-active azoles. When we started using them prophylactically, we saw breakthrough infections and clearly a shift in the epidemiology. And this is taken from a nice study in lung transplant recipients where they have compared the epidemiology of breakthrough invasive mold infections versus non-breakthrough invasive mold infections. And then you can see that in the breakthrough invasive mold infections, there are definitely more Mucorales infections. And if you focus on the Aspergillus infections, these are not caused by the typical Aspergillus fumigatus, but more by rarer or cryptic species like Aspergillus justus and others. These species are often more resistant and more difficult to treat. So trying to summarize a little bit the breakthrough invasive fungal infections, what we know here is that if you have a breakthrough fungal infection because of non-compliance of the patient due to his oral intake, or there is insufficient exposure due to erratic intestinal absorption, or when you have severe drug-drug interactions that result in subtherapeutic drug concentrations, then you can consider going from the oral formulation to the parenteral formulation, or you definitely have to change class of drugs. However, if you have a breakthrough infection with a pathogen that is resistant to the antifungal drug, or in a compartment with insufficient antifungal exposure, or when you have colonization by fungal pathogens, then the recommendations are really that you consider a change of the antifungal class. And if I just look at some of the more recent recommendations here that have been published. We see that if there are breakthrough fungal infections with aspergillus species, then the recommendation by Andrew Ullman et al. Was that you start with liposomal amphotericin B, pending, of course, susceptibility testing and serum drug levels. And if you can switch to a mold-active azole in the setting of a susceptible pathogen, then you can switch back to a mold-active azole. But the recommendation is that you start with liposomal amphotericin B. The same is true for a breakthrough mucorales infection. Drug of choice there is liposomal amphotericin B, at least at a dose of 5 milligram per kilogram. And preferably, you try to increase it to 10 milligram per kilogram in case of CNS disease. And then, according to the most recent recommendation by Martin Hönigle and et al., looking at breakthrough fusarium infections, also in that setting, the drug of choice is liposomal amphotericin B at a dose of 3 up to 10 milligram per kilogram. So that summarizes more or less prophylaxis and the problems that we may see with prophylaxis, especially with respect to breakthrough invasive mold infections. Now, if we go back to our interventional options, there are two other options that we have. We can decide to start antifungal treatment, and that can be triggered by fever, and then that's what we really call the empirical approach. So when a patient has persistent fever, not responding to broad-spectrum antibacterial therapy, in that setting, we do suspect the patient to have a fungal infection. And when we start an antifungal in that setting, that's called the empirical approach. Another approach is that you have a non-fever-based approach, so that you start your antifungal treatment on the basis of something that you see on a CT scan or a chest X-ray, so on the basis of imaging, or you start antifungal treatment on the basis of a diagnostic test that comes back positive, or a combination of diagnostic tests, and I'll talk about that in a minute, or you start antifungal treatment because on the basis of positive imaging and diagnostic tests. And that is what we call a diagnostic-driven approach, sometimes in the literature also called a preemptive approach. So looking at these diagnostic tests, what is these days available in not in all centers around the world, and not in all centers in Europe, but at least in some centers. Well, this is available. You have the direct test, and usually these direct tests are available in almost every center around the world. They consist of culture, they consist of direct microscopy, and of course, tissue examination, so histopathology. And you can increase the sensitivity of direct microscopy by using specific optical brighteners. Now, the indirect tests that are currently available are galactomannan that can be detected in the blood, in the serum or the plasma, but also, for instance, in BL fluid and even in plumber fluid. And it is quite specific for aspergillus. There's beta-D, 1,2,3-beta-D-glucan that can be detected mainly in blood samples. It's more of a panfungal assay. There are PCR assays that can be panfungal or species-specific. And more recently, there is also the availability of the point-of-care test, the lateral flow assays, mainly focusing on the early detection of invasive aspergillosis. And of course, all these tests need to be combined with sensitive radiological tools, such as CT scan, or now more recently also angio-CT scan, and sometimes PET-CT scan. Now, this is nice data coming from the Spanish group, where they have combined different diagnostic tests. And basically what they did in this study is they screened their high-risk hematology patients on a weekly basis for serum galactomannan and also serum PCR. And you can see quite a large number of patients have been tested in this multi-center study. The conclusion of this, this diagnostic test study was that in the absence of any of these positive tests, so a patient not having positive galactomannan or positive PCR, that obviates the need for antifungal agents with a very high negative predictive value. In their study, they had a negative predictive value of 100%. So basically, they could say none of the test is positive when we use it as a screening assay, so this patient does not need antifungal treatment at all. Whereas the presence of at least two positive results, so presence of positive GM and positive PCR, was highly suggestive of an active infection, and they had a positive predictive value here of 88%. So they were quite confident that the patient did have an invasive fungal infection and needed antifungal therapy. So all of this is quite nice. I'm going to skip this in the interest of time. So what we recently did with the EORTC, and this was the last study that was done by the EORTC infectious diseases group, was really to compare two different approaches: a purely empirical approach that was fever-driven versus what is called a preemptive approach or a diagnostic-driven approach, where we relied heavily on CT scan and serum galactomannan. And that was tested in these two strategies in a randomized way in a high-risk neutropenic population. So here you see the design of the study. We focused on AML patients coming in for remission induction and also on allogeneic stem cell transplant recipients coming in for myeloablative conditioning. Now, these patients, upon admission, were randomized into one of these two groups, the empirical arm or the preemptive arm. All these patients received fluconazole prophylaxis 400 milligrams a day to prevent Candida infections. When they developed febrile neutropenia, we did the usual workup, looking of taking blood cultures, asking for a chest X-ray, taking the appropriate specimens, and of course they were started on broad-spectrum antibacterials. And then what happened thereafter? Well, if those patients were randomized to the empirical approach, if they developed 4 days of unexplained persistent fever, or if they had a relapse of fever after at least 2 days of effervescence, then these patients, they fulfilled the definition of empirical antifungal therapy. These patients were started on antifungal therapy. And in this case, since the study was sponsored by Merck Sharp and Dohme, they started on caspofungin. On the other hand, when patients were randomized to the preemptive approach, we did not take fever into account as a trigger for starting antifungal therapy, but these patients were screened twice weekly for serum galactomannan, and we had very specific triggers in the protocol for asking for a CT scan. And so when these patients had a single plasma or serum galactomannan that was positive, or they had a positive culture, or a new infiltrate on chest X-ray on CT scan, then these patients, irrespective of fever or of persistent fever, received antifungal therapy. And also in that setting, the antifungal therapy they started with was caspofungin. And as you can see, the endpoint of the study was survival at 6 weeks. And this is really the result of the analysis of the study, the primary endpoint, where you see that there was no difference in the overall survival in this high-risk neutropenic population. Overall survival at day 42 was 93% in the empirical approach and was 96% in the preemptive approach. The difference did not reach statistical significance, proving the non-inferiority of the preemptive treatment when compared to the empirical treatment. Now, this is all very nice, but that implies that you have these non-culture-based tools available in your institution. And as I said, this is not the case for many institutions around the world. And even in Europe, this is from a European survey where people in France contacted a large number of larger hematology centers throughout Europe and asked them about their availability for these specific tests. And as you can see, most of the centers do have serum galactomannan and BL galactomannan testing available, but only about 20% of them have also aspergillosis PCR available, 20% beta-D-glucan available. So the vast majority also in Europe has no access to beta-D-glucan. And you see that roughly 40% of them had access to PET and CT scan. Availability is important, but what is even more important is, of course, the turnaround time, because some of these institutions had the test available, but it took them 3, 4, or 5 days to have the results, to have the results back from the lab, which is clearly too long. And this more or less shows you the life cycle of a diagnostic test, where you start from ordering the test and obtaining the sample, and then you have transporting the sample to the lab. It needs to be received and processed and tested. And finally, when you have a result, that result needs to be communicated, also reported back to the clinician who has to act upon that. So if all that happens within 24 or 48 hours, then the test can potentially have an impact on the outcome of the patient. If it takes more than 48 hours, then really you cannot rely on these tests, and you cannot rely on a strategy that incorporates these diagnostic tests. So if I try to summarize before I go to the final part of the talk, we have a continuum of different approaches. And I've taken you the example of a neutropenic patient. When confronted with a neutropenic patient, the first question is, shall we put that patient on a kind of primary prophylaxis, or are we going for some kind of surveillance? Shall we screen that patient using one or a combination of the different biomarkers that are available, such as galactomannan, beta-D-glucan, PCR, or even lateral flow assays can be used for screening blood samples. And then finally, when you have made that decision and when the patient develops persistent fever, then you have two options. You go for an early diagnosis. That means that you rely again on the different biomarkers, but maybe now not only on serum samples, but also on BL samples. You also rely on microscopy, culture, and radiology. And then there is also the possibility to give preemptive treatments. Now, centers that rely heavily on a diagnostic-driven approach often start treatment empirically, but then they stop the empirical treatments when they have the results back from the different diagnostic tests. Of course, if you work in a setting where you do not have access to these diagnostic markers, then the only thing that you can do is to continue to rely on the empirical approach. And so I think there is still a place for the empirical antifungal treatment in our hematology patients, especially if you have no access, no readily access to the newer biomarkers that are presently available in some centers. So if you go for the empirical therapy, then the question is, what is the drug of choice? And this is my personal bias. I think that in our hematology patients, the drug of choice is liposomal amphotericin B. And you can ask yourself, of course, the question, well, why liposomal amphotericin B? Well, I think that if you look at the profile of liposomal amphotericin B, it fulfills the profile of an ideal antifungal agent, more or less, because the ideal antifungal agent simply does not exist. It has a broad spectrum of activity with a low risk of resistance, which is not the case for the echinocandins and the azoles. It's a drug that is available intravenously. The problem here is that there is no oral formulation, and this is the main drawback for liposomal amphotericin B. There is no oral match here, so we have to go for the IV. It has predictable pharmacokinetics with a very rapid accumulation at the infection site. This is not the case for the azoles. They have a very unpredictable pharmacokinetics. There is a low risk of acute and chronic treatment-limiting toxicities. Again, this is not the case for the azoles. This is also the case even more so for the echinocandins. And I will come back to some of the acute toxicities of liposomal amphotericin B, mainly to the nephrotoxicity. And last but not least, there is a very low risk of drug interactions. And again, this is not the case for the azoles. And this is currently becoming a major problem in our hematology population. I think we can say that the mold-active azoles have been game changers, certainly in the 1990s and beginning of 2000. But I think that the game is changing again these days with respect to the azoles. And the reason for that is that in oncology, in hematology, in the treatment of AML patients and CLL patients, we use now a lot of new drugs, new molecules, and we can say that about 50% of the drugs that we use in oncology, but also in our transplant population, are metabolized by the cytochrome P450 system, mainly by CYP3A4, and they have a very narrow therapeutic index. The typical example here would be midostaurin that we give to the FLT3 mutant AML patients, for instance. Now, when you start combining these newer molecules with strong inhibitors of the CYP3A4 enzymes, such as, for instance, the mold-active azoles like posaconazole and voriconazole, then you may end up with significant problems because you will increase the exposure of the small molecules, and finally you end up with unexpected toxicity. For instance, we've seen in the STONE study that the combination of posaconazole with midostaurin resulted in increased incidence of interstitial pneumonitis and even patients dying from respiratory distress. So this is becoming a problem these days. So what are the properties of an antifungal agent that are important to me as a clinician? Well, I usually look at spectrum, at the efficacy of a drug. The drug needs to be proven effective, of course. Definitely the toxicity, whether there are important drug-drug interactions, and whether I need to do some therapeutic drug monitoring or not. Other properties are important as well, but they may be more important for the microbiologist or the clinical pharmacist. And from a clinical point of view, these 5 for me are at least important. So coming back to liposomal amphotericin B, what do we know about the effectiveness or the efficacy of the drug? Well, we know from guidelines, and I will focus a little bit on guidelines here, that it has proven efficacy in the treatment of invasive aspergillosis. Clearly, the guidelines do recommend voriconazole or isovuconazole as first-line treatment of invasive aspergillosis, but in those settings where you cannot use voriconazole or isovuconazole, then the the next alternative or the next best alternative is clearly liposomal amphotericin B, as recommended by the American guidelines, but also by the ECIL guidelines and the European guidelines. What about the efficacy against mucormycosis? Well, the guidelines here are very clear. Liposomal amphotericin B is the drug of choice for the first-line treatment of invasive mucormycosis, especially if you have central nervous system involvement. You should start high enough, preferably at 10 milligram per kilogram. You can always go down to 5 milligram per kilogram, and of course, combine it with surgery and with better control of the underlying disease. But this is taken from the global guideline that was published 2 years ago, where liposomal amphotericin B is clearly recommended as a drug of choice. And then if you look at the empirical setting, well, different studies have been done. Liposomal amphotericin B in the empirical setting has been compared to conventional amphotericin B, where of course it proved to be better tolerated. It has been compared with voriconazole and also with caspofungin. And at least when compared with caspofungin, the study proved that these two drugs were non-inferior to one another. And so if we go back to then the guidelines, and these are the ECIL guidelines that we've put forward a few years ago, now almost 9 years ago. We say that in the empirical setting, both liposomal amphotericin B and caspofungin at these doses have been given an A1 recommendation on the basis of efficacy and safety. Now, how do you select now if you are in front of your patient whether you will give caspofungin or liposomal amphotericin B? Well, I think you can rely on these criteria. Caspofungin needs to be given intravenously, just like liposomal amphotericin B, has an excellent safety profile, has excellent activity against Candida, and that includes biofilms. But the problem is that caspofungin only had moderate activity against aspergillus species, and it has no activity against the non-aspergillus molds. So the spectrum of activity is rather narrow here. Looking at liposomal amphotericin B, that has a broad spectrum of activity that includes the mold infections, also the non-aspergillus molds. It has also an excellent Candida activity, including biofilms. It has fungicidal activity, and I think that is important in our neutropenic population, where you cannot rely on the immune system. And there is minimal development of resistance, unlike caspofungin, where we see that after a while there is a development of especially echinocandin-resistant Candida glabrata. Now, I have to talk one slide on toxicity, because many people always tell me, well, liposomal amphotericin B is indeed a recommended drug, but it is difficult to manage the toxicity, especially the nephrotoxicity. So that's why we've done in Europe this study comparing the renal toxicity, the nephrotoxicity in a prospective study of conventional amphotericin B, liposomal amphotericin B, and other lipid-based formulations of amphotericin B, like ABLC and ABCD. And what we saw from that prospective study is that indeed about 1/3 of the patient will have an increase in their baseline serum creatinine while receiving liposomal amphotericin B. However, few of them have a moderate increase, and even fewer, around 3% of them, have a severe increase of their baseline serum creatinine. So in most of the cases, the increase or the nephrotoxicity of liposomal amphotericin B is acceptable and is also manageable. And I agree, if you have moderate or severe nephrotoxicity, then you clearly have to stop the drug and go for another option. So trying to summarize before I come to really the concluding slide, when confronted with a patient at high risk of invasive fungal disease, such as many of our hematology patients, the first question is, shall I put that patient on prophylaxis? And if so, will I go for a yeast-directed prophylaxis, which would be fluconazole, or do I go for a mold-directed prophylaxis with one of the mold-active azoles, or with an echinocandin, or maybe also with a polyene? Before you answer that question, what needs to be taken into account? Well, is of course the local epidemiology. But as I already mentioned at the beginning, few centers really have a good idea about their local epidemiology, and also whether you have these diagnostic tests available in your institution, and also what is the turnaround time of these diagnostic tests. You have to know that if you go for a mold-active prophylaxis, that this will have an impact on the drug of choice for the subsequent approaches, or also will have an impact on the drug of choice for breakthrough invasive yeast and mold infections. And then when the patient is on prophylaxis or not on prophylaxis, but develops fever or a clinical scenario that is suspected of having invasive fungal infection, what is then your next step? Well, I think that the empirical treatment with any of the approved antifungal drugs is still acceptable and still justifiable if you work in a center, for instance, where the diagnostic tests are really not available at all, or you use it for a short time until the diagnosis of invasive fungal disease is confirmed or excluded based on the different surrogate markers that are available. If you have all these diagnostic tests available, then clearly you can shift from the empirical approach to a more diagnostic-driven approach. And that's an approach that you can apply in patients not receiving prophylaxis or receiving fluconazole prophylaxis. When a patient is receiving a mold-active prophylaxis, then you cannot rely on the surrogate markers because the performance is clearly decreased in that setting. And then you have to go for more aggressive diagnostic approaches, strategies, and that includes doing bronchoscopies and maybe asking for biopsies, potentially CT-guided biopsies. So really, in conclusion, I think an empirical use of antifungals remains justifiable in our hematology patients, either as a buying time strategy in the classical risk groups or else when the diagnostic tools are not available or when they have not been evaluated in the target population, for instance, in one of the emerging at-risk groups that we see these days in our hematology patients. Prior antifungal prophylaxis does have an impact on the choice of drug, clearly favoring lipid-based formulation of amphotericin B. And when we look at the toxicity profile, then I think that liposomal amphotericin B is preferred above the other lipid formulation of amphotericin B. To conclude, I think it's fair to say that more emphasis should be placed on the use of novel diagnostic tools, novel imaging tools, as well as novel tools that are available or tested in the mycology lab. So with that, I'd like to stop. I thank you very much for your attention, and I'm happy to take questions. Thank you.
Thank you, Prof. Johan. This was really a very nice review of all the area that hematologists need. If you allow me, Dr. Johan, what about the COVID-associated aspergillus or aspergillosis? This is a hot topic nowadays. And, you know, some of our hematology patients will develop COVID and they will be in ICU, and still we are not familiar with how to differentiate between aspergillus or COVID associated aspergillus, or do you think no big difference between them?
Well, it's an excellent question these days, and I think we all have seen these patients, and we all see these patients with kappa or COVID-associated pulmonary aspergillosis. There are a number of questions around kappa. One of them is really the epidemiology. In some centers, they have seen up to 20, 25, even 30% of their bad COVID patients developing invasive aspergillosis. In other centers, it has been a very rare event, so we still don't know what the exact incidence is. What we do know is that it is quite difficult to diagnose these cases for the very simple reason that you cannot rely on imaging here. All these patients come in with very destroyed lungs. So if you take a CT scan, you will see a lot of you will have a lot of different findings, but none of them are pathognomonic for invasive aspergillosis like we see with the neutropenic patients. So the problem here is that you definitely have to rely on your mycology test results. Culture is not really sensitive, so a lot of emphasis is now being placed on for instance, galactomannan, but also beta-D-glucan. And galactomannan in the BL fluid seems to be really sensitive for an early diagnosis of these cases. Also, beta-D-glucan, not on BL fluid, but on serum, appears to be useful. And of course, if you look at the treatment, the treatment is not different from what we see in the non-COVID patients. Apart from the fact that if you look at an azole, maybe isavuconazole can be the preferred azole in that particular setting, because isavuconazole has a number of features that makes it more attractive for using in kappa patients. There is no impact on QTC. You can give it in really impaired patients. There are fewer drug-drug interactions, etc., etc. But to be honest, it remains a very difficult diagnosis. And the whole idea is that you screen your patients, and that at least that there is the awareness that these patients may have invasive aspergillosis, and that you screen them as early as possible.
Thank you, Dr. Johan. Another question regarding the approach with prophylaxis with amphotericin, the low dose, which done in pediatric population. There is also a literature about septic shock early prophylaxis versus late prophylaxis, but not specifically amphotericin. Having this like amphotericin as a prophylaxis will not, do you think it will add to the resistant in the future, or do you think it's, which group of patients you think low dose amphotericin as a prophylaxis can be used?
Yeah, the difficult question because we don't have that many data, at least not in the adult population, and the reason why it has not been so popular as a prophylactic agent in the adult population is because we do not know what the exact dose needs to be. Studies have been done, small studies where patients were prophylaxed, for instance, twice weekly with a rather high dose, or 3 times a week with a lower dose, sometimes daily with a very low dose. And it's very difficult to make any conclusions from all these smaller series. The only thing with respect to amphotericin B that really has been studied quite well is the inhalation of amphotericin B. That has been studied in the AML population, also the allo-BMT population, where they received a lipid-based amphotericin B inhaled twice weekly. And that really results in a very nice reduction in the incidence of invasive aspergillosis. Of course, inhaled does not prevent, for instance, Candida infections because there is no exposure, no systemic exposure. So I think that, to be honest, there's more data on amphotericin B prophylaxis in the pediatric population, as you mentioned yourself, than in the adult one. So who could benefit from it? Basically, anyone who benefits from azole prophylaxis. But I think we need to do some more basic research on the dose.
Thank you, Dr. Johan. Now, there is a question by Dr. Afnan Noor asking about in case of transaminitis, usually how you approach, like you hold when the azoles, there is a certain limit of transaminitis, or you wait till high bilirubin?
Thanks for the question. I think we all have a different approach towards transaminitis. Usually, when a patient receives an azole and you see that he or she develops some transaminitis, I'm usually not that afraid of it, unless, of course, you go really more than 5 times, definitely more than 10 times upper limit. I would not. Then I would change. But sometimes I let them go up to 5 times upper normal values. If we go beyond that, and it is an azole like posaconazole or voriconazole, and then I try to switch them to isavuconazole. And there are series published in the literature, and we have experienced ourselves that in quite a significant number of these patients, when you switch them from to isavuconazole, then you see again a decrease in the transaminitis, and often even normalization of the AST, ALT values. But really, when a patient has 3 times, 4 times, even up to 5 times upper limit of normal, that is, for me, not a reason to stop the drug or to change the drug.
Especially with the close observation. Excellent. There is a question that about the combination of both galactomannan and the D-glucan. Are there studies to assess the predictive value of combining both?
No. And the reason for that is that there are studies for combining GM and PCR, as I've shown you. The problem with beta-D-glucan is that, especially in the hematology population, I have to say, is that you have quite a high number of false positives. There are a lot of cause of false positivity. Blood transfusion is one of them. use of immunoglobulins is another one, some bacterial infections, gram-negative bacteria, some antibiotics. So yeah, you may have too many false positives, and beta-D-glucan has not been a very popular marker to use as a screening tool in the hematology population. There is one exception, and it is if you suspect a patient of having PGP. In the case of pneumocystis, where you are waiting the results of your immunofluorescence, or maybe you wait for the results of the PCR. If in that setting you have a high beta-D-glucan value, then that adds to the diagnosis of suspected PGP. But apart from that, I don't use it, certainly not as a screening tool in our hematology populations.
Dr. Johan, in the ultra-high risk group like AML and MDS, especially if we are using the oral new agent like venetoclax, and there is a drug-drug interaction, and hematologists are worried to reduce the dose for how long. So the usual approach is to give the combination with mold-active prophylaxis for 2 cycles. What's your take on this? Like, you agree that 2 cycles or the first 1 cycle only, or the first month for AML induction patient?
Yeah, I think I agree with that approach, and whether it needs to be 2 cycles or 3 cycles, the future will tell us. But it's clear that when you give hypomethylating agents and you combine them with, for instance, venetoclax in the older AML population, we do see some more neutropenia, some more prolonged neutropenia also. But when a patient starts responding to the hypomethylating agents in combination with venetoclax, then the risk clearly becomes of developing fungal disease is going down, becomes less. So the highest risk is really within the first 2-3 courses. And given the difficult drug-drug interactions that we see with these drugs and mold-active azoles, I would indeed also favor to restrict it in time, the combination of mold-active azoles and venetoclax, and then it makes sense that you only give it during the first, let's say, 2 or 3 courses. Yeah.
Thank you. On another question, I want to ask you about your favorable antifungal prophylaxis in acute lymphoblastic leukemia, where they have prolonged chemotherapy exposure. They treat in young adolescent, for example, we give for 2 years the program. Do you think mold active needed, or in those population?
Well, there is a study done with Liposomal amphotericin B, the Ambigard study, which was, by the way, a negative study. One of the reasons is because the dose that was selected was probably not the right dose. But that study gave some nice epidemiological data showing that around 11% of the adult ALL population developed an invasive fungal disease, more mold than yeast infections, but still it was 11%, which was higher than what we had expected before the start of the study. So these patients are at risk. The problem that you have is that if you put them on an azole prophylactically, then you have a lot of interactions, for instance, with your vincristine, but also with the corticosteroids. And the highest risk is really within the remission induction treatment, where we give them high dose of corticosteroids and when they also receive the vincristine. So in many centers, they do not give azole prophylaxis because of the potential neurotoxicity when combined with that vincristine. That is clearly a population where we rely heavily on our diagnostic-driven approach. We screen them for galactomannan twice a week. We rely on CT scan, etc. Now, there maybe in the future we will have a solution for these patients, because now we are also looking at aerosolized drugs, including aerosolized azoles. And there's a new azole called opelconazole that is going to be aerosolized. There are new aerosolized formulations of itraconazole that are being tested. And I think that might be the future for prophylacting our ALL patients, prophylacting them by giving drugs inhaled, so that you have a high exposure in the lung, but no systemic exposure, and so no interference or no interaction with the antineoplastic drugs.
Nice, very nice. Looking forward for those. So, but as a nanotechnology, antifungal still liposomal is the only one, and I'm afraid really still about resistant. So in our center, we more use liposomal than before.
Yeah.
For what you mentioned, the breakthrough, we saw a lot. Before it was mainly in pediatric. Now, really, we have more breakthrough, even pre-transplant. To bridge for transplant, I have a patient who we continue liposomal till the day of conditioning, and then we also, our threshold is very low to proceed to give again liposomal. I'm really worried about the resistant, especially that not all the hospital have the sensitivity or resistant data, our own resistant profile. And but the good news, still we saw good response. I have a last maybe question about mucormycosis. We were very worried about the COVID mucormycosis. Do you still see some cases? Because in our area we didn't see COVID mucor.
No, it seems to be geographically almost restricted to India, and clearly related to the underlying diabetes mellitus that many of the Indian patients have, and then also the use of corticosteroids, which has become standard of care for the first-line treatment of COVID infection. Now, we have seen one single case in our country, and I know that in Germany, a quite large country, they have seen like 8 or 9 cases. So there is really no signal that in Europe or in other parts of the world, we see a huge increase in case of mucormycosis associated with COVID, unlike the thousands of patients that have been reported from India.
Which is very good and reassuring. Thank you, Prof. Johan, for the nice review. And I want to thank the sponsor, Gilead, for their continuous support in all aspects of educating our doctors, our fellows about invasive fungal disease, which is really a fatal disease in our population, and more transplants are done nowadays for heavily treated patients, and more agents are. So the age for our patients is increasing, and really this topic become very, very important. And I want to announce the next webinar for our series, which will be next Saturday, 18 December 2021, about another important infection in the field of hematology and transplant, how I treat CMV infection and disease in transplant. And this will be for Dr. Tamim Suleiman from France, and Dr. Mohsen Zahrani as a moderator. I hope you all save practice, and thank you again, Prof. Johan, for joining us, and thanks for Gilead. Have a nice night, everyone. Thank you.
Thank you.
Good night.